Sherman Silber from St. Louis, Missouri, and this is a project reporting between our program in St. Louis and Dr. Katsuhiko Hayashi in Kyushu and in Osaka, Japan. And we're using in vitro gametogenesis knowledge to simplify in vitro maturation of oocytes from ovarian tissue and to finally conclude about ovarian longevity. Now, our goals were first pregnancy results from cryopreserved ovary tissue transplantation from one U.S. center. And then from that to do in vitro maturation of oocytes dissected from ovarian tissue. And we're using knowledge gained from our experiments in mice from in vitro gametogenesis, where we can make functional oocytes simply from skin cells that are transformed into iPS cells. So it started with 119 females between the ages of 2 and 35 who underwent ovary cryopreservation, as well as in vitro maturation of oocytes in the last 13 cases over a 24-year period. And 17 cases came back up to 22 years later to have their ovary tissue thawed and transplanted back. Now, this is simply the way we do it. We take out an entire ovary and we dissect it in a large petri dish with ordinary media. And the dissection, we know very well from other studies, is to thin out and to get only the ovarian cortex, which is freezable and which also is transplantable. And we remove the medulla at the corticomedullary junction. And we finally have a very, very thin piece of ovarian cortex that has all the primordial follicles in it. And you can see all the little craters where there were visible follicles that emptied out their germinal vesicle oocytes when we did the dissection. And then we cut it into pieces so that it can be frozen properly. And then after the thaw, we put these pieces together again microsurgically by quilting them with 909 interrupted sutures. And you can see we have the completely quilted multiple pieces. This is our technique surgically, which we think is very important for success with ovary transplantation. And you can see we have it in a position where the fallopian tube can reach and grasp the oocyte whenever it is ovulated from the grafted ovary tissue. And these are all orthotopic transplants, and we depend on spontaneous pregnancy rather than IVF. So every patient for the ovary transplant, frozen, had a return of ovarian function 5 months after transplant, similar to previous observations, and AMH rose as the FSH went down 4 months later. So we know it takes 4 months or 4.5 months in the human for the primordial follicle to reach the GV stage and to be gonadotropin sensitive after recruitment. And these grafts, despite small numbers of eggs and low AMH, continue working for up to 8 years with many children. So 13 of those 17, 76% became pregnant spontaneously with intercourse, resulting in 19 healthy live births, including 6 live births from 3 leukemia cases. And 35% of the harvested GV oocytes developed with very simple culture media into mature M2 oocytes. And that is the exciting and unexpected finding, but not so unexpected, considering all of our prior work over the last 10 years on in vitro gametogenesis oocyte production from skin cells in mice. I just show you a very brief video of our first ovary transplantation. There's never been any doubt in my mind that I wouldn't be cured of this. Once I found out, I just made up my mind, that's it. You just have to keep taking it one day at a time and just keep that positive attitude and know that I can do this. I'll get through it.
It's 8 o'clock in the morning, July 17th, 1997. We're at St. Luke's Hospital. And we're about to do the first case in the St. Louis area of ovarian tissue freezing.
21 years later, here she is with her baby.
Okay, well, I'm Dr. Silber, Sherman Silber, the Infertility Center of St. Louis, and we really have a treat right now.
So I'm going to go to the next slide because if I showed you that whole interview, it would erode the 10 minutes that I have. This is a summary of all of our results with frozen tissue transplantation for ovarian failure and cancer. And it's a very busy slide, but if you just look at the bottom, you can see it's a 76% pregnant with delivery. 6 were vitrified cases, 11 were slow freeze. We find that it doesn't make any difference whether the tissue was vitrified or slow frozen. It's just that vitrification is easier and quicker, and that's why we use that technique. Now, if you look at leukemia cases, it's quite surprising because most people are afraid to do that, but we took the leukemic ovary out after the patient was in remission before her bone marrow transplant, which sterilized her. And so there were no leukemic viable cells in the tissue, and we have 6 babies from women with leukemia. Now, let's get to in vitro maturation, which is the most shocking part of this whole study. We use ordinary IVF culture media because our work with the mice with stem cells showed that's all you need for in vitro production of oocytes from stem cells. IVM media was no better than any ordinary IVF media, the usual human serum albumin, and you can use almost any concentration of HCG from 10 milli-IU per ml to 1,000 milli-IU per ml. And when we do the dissection, I'm going back to the slide to show we don't discard the media because that's where the GVs are. And after we're done with that dissection, we look through that spent media and we can find anywhere from 12 to 95 germinal vesicles, or at least cumulus complexes that have germinal vesicles within them. And this is what the histology shows, so that when you do the dissection, you get a lot of GVs, much more than you could get with a needle aspiration with ultrasound guidance. These eggs, the only way to get such a huge number of GVs is with actual dissection with the ovary in hand. And this is what the GVs look like, a tight cumulus complex. And it's very important not to remove that cumulus until at least 24 hours. And then when you look the next day, after incubating in any combination of HCG and in any media, you find 35% normal metaphase 2 oocytes. And this is a summary, which again is busy, but you can see we average 35%. And the only case where we didn't have a high maturation rate was the second case where we stripped the cumulus immediately, and that results in a terrible result. So if we look at all the other people that are working on this, everybody seems to get similar maturation rates of 30 to 35%, depending on, with any different combination of media. And Anderson has already shown in the discussion section of this that 64% of such oocytes are euploid, no different than in any other young woman. And the total number of oocytes was similar to that obtained after ovarian stimulation. So there's no need for ovarian stimulation. Question comes up whether these oocytes are functional like our oocytes in the mouse are. And sure enough, Seekers has already shown live births from these oocytes. It takes a long time to develop a series of these. The patients have to come back after their cancer is cured. But it's very clear that these oocytes are functionally normal. So the question is, why does it not require special IVM media? Why does IVM work so easily? And to understand that, you must understand in vitro gametogenesis. Now, this is again a busy slide, but if you look at the last 3 lines, there are 3 important phases of in vitro gametogenesis: IVD, IVG, IVM. IVD is just the differentiation of those cells. That's from primordial follicle to GV. And then the next is 11 days, remarkably the same in the mouse as in the human, of in vitro gonadotropin sensitivity. And then finally, 1 day of HCG culture, IVM, is all you need. And this is a diagram from our early studies in the mouse demonstrating these 3 phases. But these 3 phases also occur in the human. And this is our diagram of it. And this diagram is probably the most important part of the talk, because you can see that it takes 4 months of IVD in the human for gonadotropin sensitivity to occur. Then you've got only 11 days of sensitivity to FSH, and that's all you need. And there is a sweet spot of about 4 out of 11 or 12 days where the GVs will mature and they're not post-mature. So only 35% of GVs on any given days are in this sweet spot. And that explains why it works. So concluding from basic science, you do not need ovarian stimulation for oocyte maturity. FSH has already created GVs with meiotic competence, And you don't even need the normal ovulatory cycle for meiotic competence. You only need ovarian stimulation or the ovarian cycle for a way of getting the oocyte out of the ovary. So thank you very much. This is our team from Japan in Kyushu. They work very hard together. That's Katsuhiko, the tall guy in the center, and I'm the very short guy on his left. And it's been a tremendous collaboration doing in vitro gametogenesis and IVM with this Japanese team. Thank you very much.